Pregnancy is 10th week, she is HPEG positive. How will you proceed further? How to prevent MBCT?
Okay. So, hepatitis B is of a very significant finding in pregnancy, because the perinatal transmission means that there is a 70 to 90% chance of having a chronic infection in the child. So, we need to risk stratify these patients. The strategies are mainly HPV DNA viral load. So, if the viral load is more than 2 lakhs international units, then we should think of prophylaxis with treatment, prophylaxis of the child with treating the mother in the 3rd trimester from 28th week onwards. Tenofovir is the drug of choice, and there is evidence accumulating for use of TAF also. So this is the first thing. For the child, we need to take 2 measures. As soon as the child is born, we should give the first dose of vaccine and hepatitis B immunoglobulin. Both are given as IM, but we should choose different sites for the injection, and preferably within 12 hours itself. More than 24 hours later, the vaccine may not be of much use.
So the dose which is given at child is called birth rate vaccine. The coin is termed by Amrita Institute of Cochin. The birth rate vaccine. In addition to other things, this is very important. Within 12 hours is ideal to give a immunoglobulin 0.06 units per kg body weight. Third, of course, by these methods we can only prevent 95% transmission. Only by giving the mother tenofovir from 28 weeks, when the count is more than 2 lakhs, then only we can safely say, because the commonest way a patient can get a chronic hepatitis is only by neonatal, the vertical transmission, not the horizontal transmission which occurs in the adult. Of the C virus, what's that?
In C virus, actually there is no means of predicting the risk of perinatal transmission, and it is much lower than the hepatitis B. We don't have safety and efficacy data sufficiently for the directly acting antiviral treatment options. So, treating during pregnancy is not routinely recommended. General trend is that the HCV RNA levels go up during the pregnancy, and once they deliver, there is a drastic drop in the HCV RNA levels. Sometimes they even go into sustained remission. So, generally they are given only close monitoring, and no treatment or preventive strategy specific are there.
Okay. So you told now last 3 chapters. I think it's a big chapter. So far you're talking liver. I'll go to the gastro point. We already covered complaint of reflex, gastric reflex. We have IBD, immunosuppressive therapy, and constipation. Don't say constipation in the lower bed. It is also important. So they have complaint, they come commonly with constipation. IBD. Patient is a known case of IBD. Patient is got pregnant. Indian patients will not, they will be pregnant in some more. Whether cirrhosis, Wilson's, all said and done, they get pregnant. That's the problem. The question is Alagama and Malawi. The twin retek tupaki enna panrappa. Or risk of IBD, screening for IBD in pregnancy. What is the role of intestinal ultrasound? Kyle is going to talk on intestinal ultrasound tomorrow. But there is indication for intestinal ultrasound. What is the role of mesalamine and other drugs? Do you use methotrexate, thalidomide, and ozanimab? Any use of biologicals in IBD in pregnancy? Role of cesarean section, when, how, and why?
See, with regard to IBD, most of the IBD patients are young, so they are supposed to get pregnant. In that period, they are having IBD. So we can divide this patient into 2 groups. One is who are in absolute mucosal remission. Somebody who is having IBD on follow-up with us, properly compliant, responding to treatment, that is a good patient. If that patient is in complete mucosal remission, as documented by a fecal cal of less than 200 or a documented colonoscopy telling that there is mucosal remission, that patient can be allowed to become pregnant. And she can be educated to continue the maintenance therapy throughout pregnancy without fail. And for her, the outcome with regard to pregnancy, both the maternal and fetal, is no way different from a non-IBD patient. It's going to be good. And these drugs are all safe. The maintenance drugs, what are the maintenance drugs that we are going to use? Commonly we use azathioprine, or we use one of the biologicals, anti-TNF is commonly used. These 2 are safe to be continued throughout the period of pregnancy. Tofacitinib is contraindicated both during pregnancy as well as lactation. So if the patient is in remission, no problem, we can allow them to become pregnant, and ensure compliance of maintenance therapy throughout pregnancy. Suppose if the patient is on biological as the maintenance therapy, the issue is giving live vaccine for the child after birth. So if the patient was on biologicals, live vaccine should not be given for first 6 months after birth. That is the only issue, otherwise no issues. The second group is somebody who is having active IBD. What generally happens is our patient who was in remission will not come back. Patient would have stopped medications, got married, and then got pregnant, and then patient will come. That is also a very, very common clinical scenario we'll see. So that patient is at risk, both maternal as well as fetal. So because IBD can go for flare-ups because she was not on treatment, she is having active mucosal disease, and now she will come with active clinical relapse. So that patient is difficult to manage because this patient needs an induction regimen for induction of mucosal remission. So the steroids are problematic. As madam was telling, the steroid given in first trimester is associated with higher congenital heart disease as well as cleft palate, though it is a conflicting data, but it is a popular belief that steroids are better not given in the first trimester. Biologicals are safe for induction therapy, so we can give both infliximab or adalimumab as the choice by the patient. For the maintenance, as usual, the previous we can continue. Problem with the active disease during pregnancy is the maternal problem, malnutrition, anemia, hypoalbuminemia. So this in turn will lead to IUGR, small for dead babies, preterm, higher chance of LSCS, poor fetal growth, all these things, oligohydramnias, all this risk will happen. So better we educate the patient to achieve mucosal remission and then allow the patient to become pregnant. But certain drugs are not to be given. Most important is methotrexate. So if the patient is on methotrexate as a maintenance therapy, which is not commonly seen in our scenario, so if at all she is on methotrexate, we have to stop at least 6 months before the planned conception and then go for an alternative. Yes. And MMF also is contraindicated during pregnancy. Usually our autoimmune hepatitis will be on MMF rather than IBD. Right. So MMF also should be stopped at least 3 months before the planned conception. And all the patients on azathioprine should be on folic acid. All the patients on mesalamine should be on folic acid in order to avoid neural tube defects. Mesalamine is absolutely safe during pregnancy.
Regarding cesarean, sir, there is an active fistulizing Crohn's, we can go for a cesarean section, as well as pouchitis infection, where in that case we can go for a elective cesarean section.
Okay, whether it is contraindicated. What about the steroids? They do cause a teratogenic effect. Evidence is not so against them, but we have some doubts. The mode of delivery, vaginal birth should be avoided in patients with active perineal cons, perineal abscess and active rectal disease. Prior complex specialized disease should be considered cesarean birth. Now we talked about intestinal ultrasound.
Intestinal ultrasound is gaining lot of popularity. I think it will be a routine practice in future, not only pregnant women, but our regular IBD patients also, because it avoids the radiation exposure as seen in CT and avoids the cost of MRI. The difficulty in the MRI and cost of MRI can come down, but it needs a dedicated, trained radiologist who really allots time for doing ultrasound among the busy ultrasound done for many other purpose. So intestinal ultrasound is based on the bowel thickening. The normal bowel will be 2 to 3 millimeters. So based on the bowel thickening and peri-bowel vascular stratification, there are a lot of criteria to diagnose. Our pregnant patient cannot undergo CT and cannot undergo repeated MRI also. So intestinal ultrasound will take over the job of assessing the active disease. Like fecal calprotectin, this also will be a useful modality.
I am not going to details of intestinal ultrasound because tomorrow the talk will be given on intestinal ultrasound by Kyle. Further details will be available in the lecture. But we are concerned with pregnancy. Okay, last few slides. Immunosuppressive in pregnancy, Dr. Arun.
So immunosuppression.
Do they get pregnant? Yes, they do get pregnant.
Chronic liver disease and immunosuppressive therapy both are conditions which might reduce the chances of becoming pregnant, but pregnancy can occur.
In spite of everything occurs.
Yeah, so if pregnancy occurs, then we may have to avoid MMF, methotrexate, etc. and try to manage with minimum dose of prednisolone as much as possible. If necessary, can add on azathioprine.
Mycophenolate is contraindicated. Okay, lowest dose. Last slide, last chapter, constipation pregnancy. It is not trivial. Please, heaven's sake, it is also important. They complain commonly in constipation. Poppy, what is chance of constipation in pregnancy? What is the role of drugs which are considered okay?
Constipation is seen in 20 to 40% of pregnancy. It's mainly due to dysmotility, the hormones, progesterone, can lead to dysmotility and cause constipation. Also, the compression of uterus over the colon can lead to constipation. So, in the postpartum period also, the patient will come with acute fissure because of straining during the time of delivery. They will come with fissure, hemorrhoids as well as bleeding PR. So, the fissure itself will cause further spasm of the sphincter and cause constipation.
What is the drug better?
So, dietary modification has a major role. They have to take plenty of water as well as fiber containing diet. Bulk laxatives can be given. During pregnancy, stimulant laxatives is better avoided. So,
You want to avoid only stimulant laxatives. You can use bulk laxatives like psyllium and methyl cellulose, but you avoid stimulant laxative like bisacodyl.
Bisacodyl.
Right? Okay. Some people say hydrocodone foam. Any of your experience in the panelists for hemorrhoids in third trimester? No adverse events have come. Is the role for hydrocodone foam for hemorrhoids in the third trimester?
So, better can be given.
Okay. So, dietary fiber, lactose and polyethyl glycol, avoid
Stimulant.
avoid
Stimulant laxatives.
So, pregnancy related disorder is a big chapter. It's a singly theme conference. I thank the panelists for actively seeing all my slides. It is big, bloody bore, but they are able to get the extract correctly. We have considered certain salient points only. This is based on ACG guidelines for liver and pregnancy. Also, some include GI disorders also. There are a lot more disorders. This will be a guide only. We have to future guide for future reference, and our aim is to avoid complications for MMR and IMR. So, thank you. My cat actually what I'll say, I hope you
Thank you, speakers and moderators. Now I would call upon Professor V. Jayanti Madam, Professor P. Ganesh Sir, Professor A. Murali Sir to sum up today's session.
Thank you, thank you Venkat, and thank you panelists. Women are doing a wonderful job. Come out of the dice.
Thank you.
It's working. It's not working. It's working. You're getting old. So I'm sure you all enjoyed today's session. Okay? Many have left already, but I think all that was addressed today, I think, was of immense importance, at least from examination point of view. And I think LBK has chosen wonderful topics, and tomorrow it continues with all the debates and various sessions, panel discussions. So I think we'll continue that tomorrow. So just to summarize very briefly, we had the first oncology digestive session that was spearheaded by Dr. Sridhar Sundaram and from Tata Memorial. And the first talk was by Dr. Tirumurthy, and he gave us some sessions on, he discussed some of the challenges in placement of the nasogastric tube. Then he also discussed extensively, I think, on the nausea and vomiting as a chemotherapy in management of nausea and vomiting. And he highlighted the 4-drug regimen with a focus on palinosetron. I think that was a new drug even for me. And there was an extensive discussion on management of mucositis, and Dr. VGM also addressed some of his personal experiences with that. So this was followed by Dr. Murali Rangan, who spoke on management of viral hepatitis in patients who have oncological problems, and he highlighted the role of triple strategy panel assay in patients with hepatitis B virus infection. He also addressed on HCV and HEV infection, chronic HEV infection. I think that was also well discussed. Then we had Dr. Badivel Kumaran, who spoke extensively on radiation proctitis, and he came out with the information there are no set guidelines, and ultimately it's the individual's experience to highlight some of these problems. Then we had a wonderful session on case discussions by Dr. Sridhar again, who addressed on various aspects right from esophageal cancer, the biliary tract cancer, the colonic as well as gastric cancer. And I think that was a wonderful session. It was typical OSCE type, and I think probably that's the type that's going to come up even in the national board level. And finally, this was followed by, the final session was by, again, Dr. Murali Rangan, who's addressed on the various hereditary and familial disorders of colorectal cancer. And I think it's very important from examination point of view. These are all the viva questions that are asked. No, is it germs and mutation? Is it all those? So I think please read up all that. And I think LVK have done a wonderful job. That session was well addressed, and I think it was of immense value. Thank you, Dr. Ganesh. You can summarize the next speaker.
Won't keep you long. So there was a discussion on pancreatic fluid collections, and then Sudipto talked about infections and acute pancreatitis, and he stressed on the Atlanta classification, and it is very important that you stratify the acute pancreatitis into mild, moderate and severe pancreatitis, because it gives you a prognostic index. And Sudipto also stressed the need for antibiotics. He said that it is usually not required except in select situations. Then Dr. Matthew discussed on the drainage of pancreatic fluid collection. Generally what you should remember is that you allow the pancreatic complication, fluid collection, time to probably resolve by itself. So at 6 weeks time, if it doesn't resolve, then it becomes a pseudocyst or it becomes an infected necrosis. And the situation is that if it requires treatment, then you intervene. In pseudocyst, it is usually EUS guided. Rarely, you can have a percutaneous or surgical approach, limited, minimal invasive. Coming to necrosis, there was a stress that generally minimal surgical intervention is the choice mostly, followed by endoscopy if it is feasible. Most of these patients are very critically ill. Sometimes the fluids have to be relieved as early as possible. Sometimes they do a percutaneous approach and then try to see whether you can remove all the necrotic material as much as possible. It was highly stressed on this point. Dr. G.V. Rao gave an excellent lecture on the role of surgery in pancreatic necrosis. Again, he stressed that the surgeons have an equally important role to play. So you should remember that all patients are not yours. Depending upon the clinical condition, you probably require a multidisciplinary approach. You need to make a team, keep them in the loop. You can't deal with all patients. There are certain patients where you cannot do an endoscopic procedure. In such situations, you need to get the help of the surgeons. The surgeons will do a better job than you rather than complicating the issue. So he gave a very good talk on surgical approach. And then he also dealt with the time duration when he should do a lab chole in a patient who's had a biliary pancreatitis. And the take generally on literature is that you wait for 6 weeks and then you take both. If there is a fluid collection to be drained, you can do endoscopically and then you can do a lab chole. But there is a chance that these patients can have a recurrent biliary pancreatitis if you delay further. So he stressed that most patients who are stable should undergo a lab chole as early as 14 days after the first episode of biliary pancreatitis. He also stressed that it is not anymore EUS alone or ERCP alone. It is always EUS with interventional radiology or EUS with minimal surgical approach. So the roles are well defined now in the literature, and probably you should be reading about what is the current clinical guideline before you probably embark on treatment strategy. There is a role for ward in patients who are very sick where you want to remove the necrotic material. Posteriorly, you probably do a small endoscopy which is passed through a puncture, and then you remove all the necrotic material. Then coming to GI emergencies, G.V. Rao again extensively talked about iatrogenic perforation. As residents, after completing DM, one should be quite humble. I think one should not think that you can deal with all problems. If there is a difficulty, you should call your senior or probably postpone the procedure till you find out what went wrong, why you couldn't complete the procedure. So iatrogenic perforations are usually more common when you don't plan your procedure well. So if you are very aggressive, then you may land into problems. So whenever you take a person for endoscopy, make sure that you know the proper indications for that. It is very important that you be guided initially and make sure you don't do procedures where you are not properly trained. You need to get trained before you do those procedures. And all this can be avoided if you are careful enough. There's a beautiful talk by Dr. G.V. Rao on iatrogenic perforation. Then Palani talked on post-EVL ulcers. It was again a good talk, very composite. He dealt with all the factors which can cause a post-EVL ulcer and how you should be careful when you band. You should not apply more than 6 bands, I agree. And you will always look out for red out sign before you deploy the band. Don't deploy the band by doing a very forceful suction. If it is not coming into the hood, then it is not the varix, it is probably the submucosa. Make sure you follow all the procedure before you apply the band. In spite of that, you might have complications, but you should be able to predict which patients will develop complications. Child class C, patients with previous bleed, patients who are septic, or patients who probably will have high chance of post-EVL ulcer bleed. You need to be very careful. Treatment is only PPI and sucralfate. Sometimes you can inject glue if you have a point where you can go below the band. In an emergency, IR people should be informed in person and then probably tips may be required. Vishnu talked about removing foreign bodies and he gave a wonderful talk. I think he again covered the entire topic. It's important to know that patients who have, most of them are children. So sharp objects, long objects, large objects are objects which have problems in removal. You must make sure that your unit has all the accessories. Please don't use a biopsy forceps to remove any foreign body. You should have a foreign body removal forceps. You must have a Rothnet. You must have a snare. Otherwise, I think if you don't have the proper accessories, don't attempt to remove foreign bodies from the stomach or esophagus. Again, he talked about foreign bodies stuck in the cricopharynx. That is not your area. Please don't attempt any removal. Please call your ENT surgeons. That point was well stressed. I think that is a very good take-home message. I still remember one case where there was a blade which was swallowed, got stuck in the cricopharynx, and endoscopists tried to remove with catastrophic consequences. It just cuts across. Then you have a problem. So please don't do that. Make sure that wherever you go, you have all the accessories. Observe a few cases before you remove. Most of these patients usually come at uncommon times, especially children. And if they have swallowed, most of them swallow coins and button batteries. Button batteries have to be removed as early as possible. Don't wait or procrastinate. I think there is an emergency endoscopy service. You must be able to remove the button batteries as early as possible. Because there's a problem here, because most parents try to give banana, try to give so many foodstuffs to make sure that it moves down. Then you have a problem, you cannot identify the foreign body. Then how do you identify the foreign body? You must use a CM. Make sure that all opaque foreign bodies you will be able to identify with the CM, either in the fundus or body, and then you go and either grasp it with a forceps or with a Rothnet and try to remove. This is a very important trick you must keep in mind. Okay. Again, Dr. Matthew again dealt with the non-variceal bleed. It's very important that you resuscitate the patient at the earliest. Blood transfusion is usually required if the hemoglobin is less than 9, otherwise it is not required. Plan your endoscopy. If he comes in the morning, it is easy. If he comes at night or midnight, you probably resuscitate, then do an endoscopy within 12 hours to see whether it requires any endotherapy. So Forrest classification is very important. Based on that classification, you probably have to take endoscopy further. So all endotherapies have to be completed within 12 to 24 hours. There are chances for rebleed. Those with Forrest 1, A, B, 2, A, B may rebleed. So these patients may require a relook endoscopy. Otherwise, everybody does not require a relook endoscopy. It's very important. So make sure that you are well trained in probably arresting non-variceal bleeds. There may be complications. Using of thermal energy should be very careful. Using hemoclips, you must learn to use hemoclips. It's very easy, but it should be done under supervision, and then you can probably get the confidence to do it alone. I think that sums up the emergency and the pancreatic one. I request Murli to sum up the final.
Hello. Good evening, everybody. At the outset, I thank Dr. Elvika and his team for giving us the opportunity to participate in this esteemed conference conducted by TNISG Tamil Nadu chapter. Now, the last topic, which is covered by excellently by Dr. Venkateswaran and his team, on the GI disorders, including liver diseases in pregnancy. Initially, he talked about hyperemesis gravidarum. The important point that you got from the discussion is the causes for the various causes which have been attributed to hyperemesis gravidarum, and which is stressed on the Puig score, which everyone should note to decide about the intensity of the hyperemesis gravidarum. And the most important driving point which we learned from this discussion is when you think of when the patient has got hyperemesis gravidarum, rule out the molar pregnancy, which is one of the important cause for the hyperemesis gravidarum. Then came the indications of endoscopy in the patients with pregnancy. Everyone emphasized that pregnancy in the endoscopy in the second trimester is very safer. So if there's an indication, you can definitely do it with less risk in the second trimester when indicated, that too when indicated. Similarly, the dealing of gallstone in pregnancy has been well dealt, and everybody agreed that the gallstone, which is a simple biliary colic, should be managed conservatively as far as possible during pregnancy. When intervention is required, like acute emergency condition like acute cholecystitis, where there is need to be surgical intervention necessary, it can be done, whether it's the first trimester, or second trimester, or third trimester. And also the indications for ERCP has been stressed. When the patient has got cholangitis and got a hyperbilirubinemia, we can nowadays, with the available of latest advances in CT imaging, with the imaging modalities, we can safely do ERCP when indicated in a pregnancy. And then the cholecystitis of pregnancy has been stressed, and it has been emphasized that bile acids of more than 100 micromoles is very dangerous, and especially when you deliver, then we can plan delivery when the level is more than 1000 micromoles at 36 weeks of pregnancy. But rarely it produces problem. We see most of them become better, and you must know that once the patient has got intrapediculosis of pregnancy in the first pregnancy, she is likely to have in the second pregnancy also. Another thing about the gallstone disease is the postponement of surgical intervention. As I say, the indication of course, surgery has been emphasized when there's acute cholecystitis, but the patient is symptomatic but doesn't have any complication, we can always postpone. If it is the first trimester to the second trimester, if it is the second trimester, try to do the surgery, or if indicated, if it's the third trimester, at least try to postpone the surgery to the postpartum period. And in my personal experience, I have 2 gallstones whom I had seen symptomatic pre-marriage. I advised them to have a surgery before marriage, but exactly as I told, those 2 girls got pregnant and they become symptomatic in the second trimester. And luckily, with conservative management, both have come out of the she had a mild obstructive jaundice pancreatitis which got settled. And when they called me from the gynec ward that they had a problem, and I was monitoring, and they said before discharge, I want them to get operated for the gallstone before the post delivery. This is a planned cesarean, but said that we have to look after the child, and they postponed. After coming home in the postpartum period, again, and this time the patient developed a severe pancreatitis. She went for a shock, and then it's very difficult for her. Of course, she came back, but it was a very stormy course. So my personal advice, I think most of you will agree, if you are able to see an adolescent or a young girl, especially who is symptomatic, pre-pregnancy, better advise elective cholecystectomy before they get married. This is a very important message. And at least you tell them whether they take it or not, because it is our duty to tell them if a young adolescent girl before marriage comes with or without symptom, please emphasize on laparoscopic cholecystectomy, because when they get complications during pregnancy, it's even if they, without pregnancy also you know about the complication, and during pregnancy it's very, very difficult to manage. And nicely they have discussed about the HELP and acute fatty liver of pregnancy, and Dr. Aragami beautifully emphasized the INR of 1.5 almost suggests AFLP and the need for delivery or termination of pregnancy at that time. And they also emphasize the low dose aspirin for preeclampsia. And similarly, hepatitis B has been well dealt in pregnancy. Everybody agreed that the viral load of high viral load, and we can start the treatment at the 28th week of pregnancy. And they emphasize the role of hepatitis B specific immunoglobulin, and the first dose of pediatric vaccine should be given immediately after birth. And I also emphasize when the cord blood should be sent for HPSAG patient when the child is born to the HPSAG positive. This will give how the child is going to behave in the next part of the life. So I emphasize the check. I don't know whether nowadays the people are checking all cord blood of the fetus born to the hepatitis B mother should be also checked for hepatitis B before. You need not wait for the report. The cord blood should be sent, and the child should be vaccinated with B and also receive immunoglobulin. And hepatitis C pregnancy got no role of, usually though they have a flare up, they will come up, and we don't start giving any antiviral. We can always start antiviral if necessary after they recover. Similarly, IBD has been dealt. It's very difficult to manage IBD, and Dr. Aragami emphasized though the patient who come with a flare is usually because for during marriage and after marriage they don't want to continue the medicine which they have been taking for IBD pre-marriage, and they stop, and during marriage they come with a flare. So it's very difficult to manage, and they emphasize that we should not give methotrexate and MMF as a immunomodulatory drugs during this period, and other medicine which are they already on, they will continue. Similarly, immunotherapy has been emphasized, and the low dose of steroid and also azathioprine, if indicated, can be given. Similarly, the most important problem is the constipation which you get in pregnancy, attributed to the gravid uterus pressing on the rectum and colon. And it has been very much emphasized that the bulk laxatives and bulk laxatives can be more safely used rather than the stimulant anti-constipating agent, because they will produce more pain when you use the stimulant constipating. By and large, it has been well covered within a short time of 1 hour. I think this will give, I think this kind of PG lectures gives more insight into the practical problems not only for the PGs, also for the young gastroenterologists who are starting to practice. And I think I would thank LVK for organizing such a wonderful topics for the especially well thought of completing the entire gastroenterology and hepatology course. You know, and I thank once again the organizers for giving the opportunity.
Thank you, dear professors, for the wonderful sum up of the entire event. This marks the end of today's session. Before we break up, a few important announcements. Kindly be seated. Just two, three announcements before we leave. Stage. Ganesh sir. Few announcements before we break up. Few announcements. The dinner will be served in the lawn of the main auditorium. Second, tomorrow the conference is in the main auditorium and it will start at 9 a.m. and the registration will start from 8 a.m. Hands-on workshop will be from 7:30 to 9 in the morning. Breakfast will be served in your hotel from 6:45 a.m. 7:30 exactly, the hands-on workshop will start. For the postgraduates, for the bus is available from 7 to 7:15. 7:15 exactly, it will take off from IBUS. Second service at 8:15, it will be available. And after the dinner, the bus is available for the postgraduates to take you to IBUS. Also, the venue for gala dinner has been shifted to VV Farms. Bus and car is available for the same.